So the abstract I want to talk about today is a multi-institutional effort to better characterize and define engraftment syndrome in patients with relapsed Hodgkin lymphoma who received immune checkpoint inhibitors as part of their salvage treatment before autologous stem cell transplant. And so as everybody knows, immune checkpoint inhibitors play a major role in treatment of Hodgkin lymphoma patients. But in the past several years, we've seen a move from third-line setting where we used nivolumab, pembrolizumab in sort of a palliative goals of care. And now these agents are moving to second-line or even front-line setting. And so we are getting used to some of the toxicities that are unique for immune checkpoint inhibitors, but I think the big question is whether the toxicities are similar in third line and beyond versus some of these other earlier settings. And so one of our excellent fellows, Dr. Tarento, led an effort. It's, as I said, multi-institutional effort to gather data on patients from the current era who are receiving immune checkpoint inhibitors as part of the salvage. And there have been some signals from the pivotal trials that use these therapies that perhaps engraftment syndrome could be one of these unique toxicities during the transplant itself. Engraftment syndrome in general is kind of poorly defined phenomena. It's been described in transplant literature for decades. It's felt to be due to sort of inflammatory cytokines released by activated leukocytes during engraftment, and it's not perfectly uniformly defined, but usually the definition includes fever, non-infectious fever during engraftment, and some other inflammatory issue like colitis, rash, or pulmonary infiltrates. So what Dr. Tarento was able to gather information on 53 patients from several large transplant centers in the US, and majority actually received BV-Nivo as a salvage therapy. Some received other regimens like Pembro-GVD. And what she found is that the total about 70% of patients actually were found to have fever that was not purely infectious fever, and it was around the time of the engraftment. And then other findings were that maybe 20 or so % of patients were diagnosed with engraftment syndrome by the treating provider. And again, about 15% of patients in this cohort received steroids as potentially effective treatment for engraftment syndrome. The other findings were, which I think is important, is there were no deaths related to engraftment syndrome. So it seems that the steroids appear to be effective management, and the outcomes in general were excellent. So again, this is helpful to know that almost 80% of patients in this cohort, and these were all non-trial patients. It was patients from outside of clinical trials. Their progression-free survival at 2 years was estimated to be almost 80%. So I think this is just sort of a start of an effort, and I know Dr. Tarento is gathering more and more data. I think once we have larger numbers of patients to sort of study and look at, we hopefully will be able to also identify some of the potential risks that may predict for development of engraftment syndrome. I think what will be also essential is to better define what engraftment syndrome is, and it may be a little bit different in this current era with the PD-1 inhibitors than from 20 years ago when this was described in slightly different settings. And so I think, again, this is an ongoing effort, but very important, just because it's important to make transplant docs aware that this may be happening, and better description, more information, I think, will be ultimately helping our patients.